Well, good afternoon. I'd like to welcome our guest, Dr. Kathleen Mazor. She's a professor emeritus with the University of Massachusetts Chan Medical School, a Department of Medicine. She is trained in both psychometrics and qualitative methods. Her research interests include physician-patient communication, health literacy, disclosure of medical errors, and medical decision-making. She has led and collaborated on numerous studies investigating the impact of various strategies for communicating health-related information to patients and to the public. A consistent theme in her research is to understand the patient's perspective on health and healthcare. Today, we're going to be discussing her recent publication in Patient Education and Counseling. It's called Lung Cancer Screening: What Do Physicians Say to Reluctant Patients, and What Do Patients Want Them to Say? So welcome, Dr. Mazor.
Thank you.
And let's start by talking about the main research question for this study, which is a mixed methods study, and why you and your collaborators decided to focus on this area.
Yeah, well, let me even start a little bit before that, because in a way, this is kind of an example of an opportunistic study in the sense that the thinking around this work, I started working on it. I've been interested in physician-patient communication for a long time. And back in the early 2000s, I started thinking about kind of how could we do a better job measuring communication. And as you said, my training is in psychometrics. And so, in psychometrics, you try to measure things. And measuring physician-patient communication is hard. It's hard to get into encounters and record things. And it's time-consuming, expensive, lots of issues there. So I came up with an idea that we could do it kind of virtually, which a lot of people do with standardized patients. But my thought was, well, what if we did slices where we didn't, at that time, there was no AI, at least nobody that I knew of had heard of it. And so my thinking was, well, what if we gave people a single situation, kind of a prompt, and had them respond to that, and we captured their spoken response, because I do believe that spoken responses are quite different than written responses. So at that point, we had someone we were working with who was able to program it in, believe it or not, Excel. And we had kind of a little prototype where you had to kind of bring the laptop to people to capture their response. But we were able to later, and I don't remember exactly what year, but a number of years later, the National Board of Medical Examiners got interested in the idea, and they put some resources behind it and created an app, which we call the video-based communication assessment. And so we had been working on that, developing vignettes and cases and thinking about that, and gathering data, testing it out, learning about it. And then I'm kind of trying to circle back to your question, Kathy, about kind of what this research question, well, as you probably know, lung cancer screening is an important topic, but it's not an easy topic for physicians to talk to patients about, because it's not a simple decision. There's pros and cons. People, actually, CMS until now has recommended shared decision-making for lung cancer screening, and you have to be eligible for it, et cetera. So it's a little bit of a tricky conversation for both physicians and patients. It's not straightforward. And so we had been, as I said, developing this new tool, and thought, well, let's look specifically at this vignette we already had some data on around lung cancer screening. So the part that I think is of interest for your class, Kathy, is that there's two kind of pieces of qualitative data collection in this. And so to tell you a little bit more about the tool and how it works is there's a vignette, what we call a vignette, or sometimes I'll call it a slice, where we set up for the physician, your next patient is, whoever. We give them a name and say kind of why they're in there, just in a couple of sentences, what you might be seeing this patient for. And then we kind of prompt to a certain piece in the encounter or in the visit. Say, okay, and after you do this, you say something. You say, well, should we get you some lung cancer screening today? Should we get that set up for you? And then, that's what the physician or medical student or resident reads that little bit. And then, so it kind of tells them, imagine this is you, you're in this situation. And then it goes to a video of a patient, of an actual person who's said that, something. And so in this lung cancer case, it was something like, yeah, I don't know. I don't really like getting any more tests than I need. Do I really need that, doc? Kind of thing, something along those lines. So they read something, they see a short video, very short video of the patient, and then they're prompted to say something themselves. So that's the first piece of qualitative data. They're speaking into the camera. We don't capture their video, we just capture their audio, and then, that gets saved. So we have that data. We were able to transcribe what all these physicians said. I think in this case, they were all physicians. We've used it with medical students and residents in different situations, but this is a bit of qualitative data across a variety of ways. Different physicians would respond to this same patient. That's the other thing in psychometrics. You worry about where you're getting variability. And in a standardized patient encounter, you can get variability in how standardized patients react. They like you, they don't like you, they do different kinds of things. They're sick of, it's almost lunchtime, they're sick of seeing medical students. Here, everybody has the same stimulus, and we capture a response. There's some data. Then what we do, and this is kind of part of what we developed with the National Board, is we take those responses, we upload them, and we get them rated by what we call analog patients. And so an analog patient is any kind of layperson who puts themselves in the place of the patient. Imagine this were you. This doctor is talking to you about lung cancer screening. What do you think? So that's what we ask them, and we call it crowdsourcing. We go through, for this study, we went through Amazon Mechanical Turk and used Turkers. So these Turkers would answer some rating scale questions. So they'd listen to one, they'd answer some rating scale questions, and they'd listen to another person. We'd batch them in batches. So you're not just listening to one person, but you're not listening to 50 people. You get a batch of less than 10 usually. So I say, oh, that one was great. I really like that one. Then I listen to the next one. Oh, maybe not so good, etc. I go through and rate them all. And then I'm asked the question, if I'm the analog patient, well, what would you have wanted the physician to say to you in this situation if that were you? And so here, now we're back to qualitative data again. I type in my response and say, oh, I'd really like them to tell me more about why I need it. Or I'd really like them to tell me how much it's going to cost, or how often I have to get it. Or I wish they would understand that I'm scared of tests or whatever. So we get a variety of these analog patients. We get, not every response is good, and some people write a bunch of nonsense. It's not useful, but we get some solid ones, and we've learned how to kind of screen and target our raters to get more solid responses. And so that's a second source of qualitative data. So now
Can I interrupt just for a second? To clarify, the analog patients, when they're providing their qualitative data, they're writing it as opposed to speaking it.
Yep.
Okay. So you have recordings from the physicians,
which they listen to. They actually listen to the recording.
Then you use those recordings from the physicians to set up your test with patients, analog patients.
Right.
And then your second source of qualitative data are these textual reactions that the analog patients have when listening to the physician responses.
Right, exactly. And for this work, for this paper, and for most of the work we've done on this, we use not the audio. The analog patients get the audio, but what we worked with for qualitative data was simply the transcripts. It's just kind of, life is complicated enough as it is. So we do get those physician responses transcribed. And so now we've got two batches of data, all these physician responses, all these patient responses. Not every patient rated every physician, as I said, but that's kind of secondary. So now we have to make sense of them, reduce them, analyze them. What do we actually have here? And so basically we do kind of what you usually do in qualitative research. They're, shorter, obviously, than a focus group transcript or an extended interview transcript, but we still go through in the same way. We say, all right, well, we read some of these physician responses. Well, what kinds of things are they doing? Oh, they're explaining why the patient's eligible. Oh, they're explaining the pros, what's the benefits of lung cancer screening. It's kind of like a fairly straightforward, or it's obvious pretty quickly kind of what your buckets are likely to be. Here's some information about pros, the plus side of getting screened. Oh, there's not much information about the potential harms of screening. There's some information about kind of why it's recommended. What's the eligibility criteria? Because it's a very kind of discrete, focused slice of an interaction, there's only so much physicians are going to say. And so it's not that hard to kind of characterize those. So we go through and we apply one or more codes to every physician response. And we kind of organize those. And then we say, like, I wonder what the standardized or analog patient said. What were they looking for? What did they say they wanted? Not surprisingly, they focus on a lot of the same things. And it's hard. I was thinking about this before our conversation today, Kathy, and once you've worked in communication for a while, it's hard not to have some frameworks kind of in your head. Patients are looking for information. And, there's only so much information, around lung cancer screening that's going to be going through their mind. And so, those categories also emerge, or those themes or sub-themes kind of emerge pretty quickly too. Like, tell me why I should get it. Tell me, under this person, I think, is a former smoker in this simulated case. So, tell me it's great that I stopped smoking. Tell me, what you can do if you find something. So they'll want some kind of emotional support. They'll want more information. And then as we went through that, we kind of, said, oh, look, these are lining up pretty well, not perfectly, but pretty well. And they also fit under a framework that I've found useful in the past that is usually referred to as the Epstein-Street framework, where they specified 6 functions when they looked at, they wrote a monograph on physician-patient communication or provider-patient communication in cancer care. And they kind of said, well, here's a helpful way to think of it. They're all interrelated, but let's think of it under these kind of major categories.
So that's almost like your conceptual model there.
Yeah, in a way, kind of a framework of that was kind of out there, and you kind of, once you're familiar with it, it's kind of always kind of bubbling a little bit in the back of your mind. So that seemed like a good match. And then for this particular study, because we had those ratings from the analog patients as well as their qualitative responses, we were able to and did look at the relationship between the various responses that we got from physicians and how those were rated, and those kind of ratings. So physician 1 gets basically a score from the quantitative ratings from patients. So we aggregate across patients and items. You get 1 score for physician 1, 1 score for physician 2. And then we can also look at, because we've kind of done this content coding on what physicians have said, we can say, oh, look at the people who gave a good explanation of benefits. Did they do better or worse than the people who didn't really explain the benefits? And we can kind of look at things that way. So we did. I mean, you can't always do that in qualitative work, and it's not definitive. This is finite number of physicians. It's not perfect, but it actually worked out pretty in an interesting way in this particular study. So so that's the gist of this, and I talked for 15 minutes straight, so I will pause.
That's okay. Oh, you're making my job very easy. So one of the things I was wondering about, actually, when I'm listening to you talk about, the qualitative and the quantitative and how they sort of fit together, and I think your table that you've included in this paper is a great illustration of that, where you have an example of a quote and then the rating and then what the patient said about it, and I think yet another quantitative element there as well, and that sort of pulls it all together. So, what I was wondering about, now you had 42 attending and resident physicians that you recruited. You had 64 analog patient raters, which you said you got from an online source. So I was just wondering about your recruitment challenges and how you overcame them, and what you found maybe was harder than it should be, and maybe you changed course now and then. What was your experience with that?
Well, physicians and residents are notoriously difficult to get. I mean, these people were paid. I don't remember how much off the top of my head, but yeah, physicians are really hard. I mean, you have to corral them, you have to incentivize them. Residents, you have to give them committed time. You have to ideally, I guess, not figuratively lock the door and say, this is what we're going to do right now, So they're really hard. Medical students can be a little easier. It all depends what the context is. And these were people, to be honest, I'm not even 100% sure where all these people we recruited them from, because we worked with the national board to get them. And they sometimes can have a little bit better reach to recruit people. The analog patients are easy. There's lots of sources for analog patients. Turk is Amazon Mechanical Turk. It's an online crowdsourcing platform. It's imperfect, and it's, this work started years ago when we started, building the app, and it's kind of hardwired, or it was hardwired to Amazon Mechanical Turk to kind of make it easy to recruit. And, there's, I don't know, probably hundreds of thousands of people on Amazon Mechanical Turk, and they're usually pretty inexpensive, although the more you restrict your criteria to get people who have good ratings and are masters and are this and that, then it does get more expensive. But there are a number of online platforms now that you can use. We've had good luck with Prolific. There's a couple other ones that that's the one I've worked with mostly. And for Prolific, I mean, you can always get people. You can get people instantly, basically, depending how much you want to restrict your sample. They basically won't post a survey or a study unless you offer at least kind of minimum wage equivalent. So if it takes 10 minutes, then it's, a sixth of whatever the minimum hourly wage is. And they'll give you a recommendation. Yeah. But then you'll get people, and you'll get them quickly, and you'll also get it easily through the IRB, because you won't have names and that kind of thing. But you'll tend to get somewhat more educated people. You'll tend to get more, it'll take longer if you want to get people between 40 and 50 who've never been vaccinated, right? Or who, whatever. So, and you can also spend a lot of money if you want to go to Ipsos or NORC or one of these other organizations, which we have sometimes done, and they'll just deal with it for you, and they'll give you, like $10,000 or $20,000. You can get 1,000 or 2,000 people who will answer your questions, and give you, we get lots of, we often have open-ended questions where we get some qualitative data on, when we do these national surveys, and it can really strengthen a paper, because if you just have a couple of tables of, older people are more likely to do this, and, people who speak Spanish at home are more likely to do that, and educated people, blah, 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 then it gets a little boring. But if you can give some, kind of color to that and some deeper understanding to that, when you ask them, well, you said you wouldn't do X, Y, tell us more about that. And not everybody does, like I said, with the Turkers too, but you can get, if you have 1,000 people, you can get enough to be able to understand people's reasons and kind of sort them a little bit, and, have a nice table that has some quotes and gives some understanding. So the one other thing I'll say, Kathy, that I thought was interesting as I was thinking about this is I do feel that what people say is different than what they write. And then that you can't get a good sense of what a physician would say if you just give them a written test. I mean, people have tried that. I've tried that. It doesn't work very well. And there are, as we've been thinking about this process more recently with the advent of AI and other new technologies, we've learned that there are increasingly more software options where it seems, I haven't tested them out personally yet, but it seems that you will be able to ask people questions through something like Prolific and get a spoken response and get them to record it, which you have been able to do for a long time if they want to upload it, but nobody wants to upload something for you. They just want to hit a button. So now there's software where you can, I believe, from what I'm reading, I haven't tried it yet except for a little sample, basically do what the VCA has done and nobody else had done for years. But now it seems like, you can kind of do it yourself and collect spoken responses in the same way that we have for this study. So I think that's really exciting because I think that opens up to get different kinds of responses from analog patients and others, and it doesn't overcome the digital divide, so to speak, but I think it would be interesting to see if we get different kinds of qualitative data when we ask people to say something to us about their reasons for not getting vaccinated or whatever, rather than to have them list them out or type them out or pick 7 from this list. So I think that's
an interesting study.
Mm-hmm.
It would be hard to figure out exactly, but
yeah, I think we could do it. But
yeah,
anyway, I think it's exciting, and if I were looking for a study idea, I think I would pursue that.
Yeah. All right. So I'm just checking my notes here. I think you've covered most of the things that I had to ask you. Here's something. If you had to do this study all over again, knowing what you know now, is there anything you would do differently?
No, I'm just worried if I did it again, would it come out as cleanly? I mean, because I think this study actually really had some very nice findings. And when we looked at, the highest rated responses, we could see, oh yeah, the elements that we identified are mostly here. I think it did a nice job. I think it was a good vignette. Not every vignette that we've written for the VCA comes out well. So no, I actually I like this study. I think it's pretty solid.
So you're happy with it.
So usually I would say, oh, there's 7 things I'd do differently, but this one I thought went pretty smoothly.
So I think that, paying attention to the methods section in this paper then is extremely useful for people who want to do something similar, that this is a sound methodology from your experience.
Yeah, I mean, and it might not come out as smoothly for other, there's other, in other work, we've looked at how consistently a physician who's a good communicator on one vignette is a good communicator on another vignette. Like I say, not every analog patient gives kind of good data, either quantitative or qualitative. And there's other, there's lots of communication situations that one can investigate. And I don't know that they would all kind of unfold in this way, but.
Yeah. What about advice for people who are just learning qualitative research? Got any advice you want to pass along? You've been doing not just on this, but other stuff you've worked on too. Is there anything for the beginning researcher that you would like to sage advice?
I think it's harder than it seems. I think it takes longer than it seems like it should. I think, what sometimes seems pretty straightforward to me about coding doesn't seem coding in the qualitative sense, not coding, writing computer code, which is how that term's often used these days. But the qualitative piece of it is important. I've learned that sometimes I make assumptions about how clear something is. This goes into category X. Isn't that obvious? And so I think attention to kind of making sure that the definitions are clear, if, for any code that you're applying. And I've just seen that that's not obvious to people. And it's just totally iterative. And so it's important to take good notes and memos or whatever you want to call it, but just document what you do, because it always seems like you'll remember, but at least I don't.
Nobody does.
Really, yeah. So it's easy to underestimate how much you'll forget. So, and probably I would start, I don't think that, I think that a survey that has open-ended responses might be a good place to start, because that amount of data can be a lot more manageable and focused than, a great big focus group or a bunch of long interviews. Interviews can be hard when you have 100 of them. So,
have you done studies with 100 interviews?
I'm part of a study now that's going to have 240 interviews with patients about their cancer diagnoses. Yeah. That's a lot of interviews.
It's a lot of interviews. Well, the analysis of those should be an interesting experience.
Yeah, that'll take a while.
It will. Well, I want to thank you so very much for talking today with our class. I got a lot out of this. I always get a lot out of talking with you, Dr. Mazor. You're amazing, and you've done some great work. Known you for a long time.
Well, no, it was fun, Kathy. I'm glad I did it, and it was fun talking with you as always. So
yes,
I'm happy to do
consistently amazing.
I don't know about that, but thank you.
That's true. Well, thank you so much.